Londres, Reino Unido, y es miembro del Comité de Ética de la Organización Mundial de la Salud y del Consejo de la Federación Mundial de Psicoterapia. Doctor Goran.
Buenos días. Good morning, everyone. As yesterday, I will be giving the talk in English and the slides will be in Spanish, and I'll try to keep them synchronized. So the topic of today's talk is treatment of complex post-traumatic stress disorder, but in order to come to that part of the talk, I'm going to remind you treatments for post-traumatic stress disorder as well. And I would really appreciate if we could close the door due to the noise outside. Thank you. So just as a reminder, and yesterday you heard a lot about froze a bit. Great. Well, I'll try to continue whilst we solve the technical issues. So yesterday we were talking about psychological trauma and potentially traumatizing events. So today I would just like to remind you of some basic concepts within psychotraumatology. So the first one is potentially traumatizing. Very upsetting, disturbing events that many of us go through throughout our lives. Studies show that between 70 and 80% of all people have been through at least one potentially traumatizing event in their lives, which is quite a lot. I'm going to show you some epidemiology a bit later when it comes to the prevalence of post-traumatic stress disorder and complex post-traumatic stress disorder. When it comes to psychological trauma, which is basically a combination of what the person has experienced and the person's reaction to it or the consequences of the experience. We have several definitions, and I wanted to present with you one by Bessel van der Kolk, who is a very popular researcher and psychiatrist who focuses on post-traumatic stress. So he says that traumatic events such as family and social violence, rapes and assaults, disasters, wars, accidents, and predatory violence confront people with such horror and threat that it may temporarily or permanently alter their capacity to cope, their biological threat perception, and their concepts of themselves. And why I think this definition is quite good, because it kind of lays out different areas of psychological trauma. So psychological trauma is not only the event. For example, I was attending a conference on trauma related to childbirth, which is also quite a common experience. Sometimes it can be very upsetting and traumatizing for some women. However, childbirth is not traumatic in itself, or it shouldn't be. But it can be traumatic under some circumstances. For example, if a woman faces severe blood loss, if the child's health is in danger, if the woman gets very sick afterwards and can't take care of the baby and receive the baby in her arms after childbirth, that type of an experience can be construed as potentially traumatic. But still, even in those cases, the person doesn't necessarily have to be traumatized in this meaning of the word. So the event itself is important to understand so we can do adequate diagnostics, because the events leading to the the diagnosis of PTSD need to be of a certain nature. And if you remember the diagnostic criteria from yesterday, the events that we are looking for when diagnosing post-traumatic stress disorder are of a certain kind. It's described in the diagnostic criteria. For example, they have to involve actual death, severe injury, loss, and so on. So it's not an everyday occurrence usually. It's something very extraordinary, something very upsetting, very difficult to process. What is also interesting in this definition is that the capacity to cope is temporarily or permanently altered. Usually when we experience a difficult situation in our lives, our functioning can usually temporarily be altered. For example, my luggage didn't arrive on time when I was coming to Guadalajara. So 2 days ago, I was very stressed because I was supposed to give a talk yesterday. That's why I was here in jeans, because I didn't have any clothes. And then I had to run through the malls, La Perla and Puerta del Sol, what's it called, and try to find clothes. And you know, I'm not probably a typical size for an average Guadalajaran, so I couldn't find any pants. So I had to present in trousers or in jeans. And I got stressed. It wasn't pleasant, of course. I don't know the city. I had to go around, shop. I was stressed, and you know, I couldn't really concentrate on anything else at the moment because I had a goal and then I had to. But I cannot be traumatized by that experience. That experience was not of a nature or a degree or a sort that could permanently influence my capacity to cope with stress. Do you agree? On the other hand, if I would have gone out to Guadalajara to buy clothes and have been robbed on the way at knife point or gunpoint, that's a completely different story, right? Because then my life might have been in danger. Or even if it hadn't been in real life, I might have thought that my life was in danger and react in that way. Probably with fear, with intense anxiety, or I would have frozen, or something else, or I would try to escape. So this level of events that we are basically interested in diagnosing post-traumatic stress disorder, they have to be extraordinary. They're not your everyday experience. Or if they are, their circumstances have to be such that they overwhelm your capacity to cope, your capacity to deal with the stress, to deal with the situation, and then leave some permanent trace. The last part of this definition I want to mention is the last part, the concept of self. Trauma has, of course, many interesting parts, but I think this one is often overlooked, how we experience ourselves after experiencing a traumatic event. For example, I've heard several times that women exposed to sexual violence or even men can be exposed to sexual violence, and it's not that uncommon, unfortunately. I just recently met a very young patient who, after being referred for a completely different reason, revealed that he was raped a couple of years ago. And no one had even asked the question. It's because we did like a structural diagnostic interview and then it popped out and then the reaction was a bit suspicious. Then I said, is there something more you would like to share? And then that person was exposed to sexual violence. But what I wanted to say was that after such experiences, or even after experiences that I described yesterday, when, for example, a person witnesses that neighbors or colleagues, which that individual had good relations until recently, do something completely unimaginable, turn into torture, and so on. The system of belief, the concept on oneself can be severely impacted. So it's very common that people who are suffering psychological trauma present with two sets of negative beliefs. And both of them are related to self-concept. The first one is that the person thinks that the world is a bad and dangerous place. And the second is that I am a bad person. What happened was entirely my fault. If I hadn't dressed this way, if I hadn't gone to the city late in the night, I wouldn't have been raped. If I didn't get in that car on that day, the traffic accident would never have happened. It's all my fault. And there's something wrong with me because other people who experience similar things didn't get sick. And I'm sick, I have nightmares, flashbacks, I can't function. So I think trauma has a very powerful capacity to influence how persons see themselves, but also how they see their environment, the people around them. I'm sure you know that people who are severely traumatized often like solitude, often like to be alone, unlike some other patient groups. I'll try to mention that later. So I think this definition is quite interesting because it kind of encompasses different aspects of trauma. And now we go back to the diagnostic criteria, and they were presented yesterday. I would still, as kind of an introduction to this talk, want to remind you of this. So we have two main diagnostic classifications, as you know. The DSM-5, which is a bit of more kind of used, given that it was published in 2013. And the most recent ICD-11 was published in 2018, but I know that translation to different languages usually takes time. I'm not sure if the Spanish translation is still available. Are you using ICD-11? You are. Because, for example, in Sweden, I think the translation to Swedish is still not finished, so basically they were still using ICD-10 codes, even though it's been a few years since ICD-11 was. So we have PTSD as a diagnostic category in both of these classifications, both ICD-11 and DSM-5. I'll just like to briefly remind you of the criteria. So the first criteria, DSM-5, it's called criteria A, is the stressor or the traumatic event, which is basically an exposure to actual or threatened death, serious injury, or sexual violence. And why is this important? I'm not sure what the situation is in Mexico, but I would really like to know more about that. But for example, in Europe, it's becoming very common to interpret some, how to put it, less than extraordinary situations as potentially traumatic. For example, a breakup, an illness which is not of a sort which isn't kind of an average human experience, economical difficulty, some other experiences which might not meet this definition according to DSM-5. It doesn't mean that these experiences aren't stressful, that they aren't disturbing, but still they wouldn't match the description of an event which basically is exposure to actual or threatened death, serious injury, and so on. And to diagnose PTSD, that's exactly what we need to be looking for, that type of it. And there's a lot of reasons why that is so. One of them is, as I understand, quite biological. The experience needs to be so frightening and overwhelming that some of our systems in the brain break down. They can't handle the stress and the fear. And then a lot of symptoms of PTSD arise from that, such as hyperarousal, for example. After we've established that the criterion A, or the stressor criterion, has been met, then we go on and kind of map the symptoms belonging to 4 symptom clusters. The first one is intrusions. That can be everything from nightmares, flashbacks, although flashbacks are basically a dissociative phenomenon, but we usually put them in the intrusions part. The second one is avoidance. Avoidance is, according to some theories of PTSD, for example, emotional processing theory, the central symptom group, important to understand and to treat post-traumatic stress disorder. And why is it so? So avoidance basically means that the person avoids 2 groups of things. The first group would be thoughts, feelings, memories, everything that can remind of the traumatic event. The second group of symptoms associated with avoidance is avoiding places, people, and situations which remind of the traumatic. If I want to have efficient therapy, treatment for PTSD, many of them basically are focused on exposure. In order to expose someone to the traumatic memory, that person cannot be in avoidance simultaneously. Or the person can be in avoidance but still meet you and want to talk about it. So a part of providing good and effective treatment is overcoming the avoidance. So the person attends the session, and so the person is not afraid to kind of get closer to these thoughts, feelings, and memories. So avoidance is a very central symptom in PTSD. The third group is changes in mood and cognition. And this category is basically not that typical for PTSD because we find it in a lot of psychiatric conditions. Depression is a classical example, anxiety-related disorders, other affective disorders, and so on. The last symptom group is commonly known as hyperarousal. Basically a sign of heightened alert, where the person cannot relax, cannot, how to put it, stop being on guard, so on. There are different symptoms that go into that category. These symptoms have to be present for more than 1 month, according to DSM-5. They need to cause clinically significant distress or impairment function. When we compared these diagnostic criteria with ICD-11, they're pretty much the same or similar. There is one difference. The changes in cognitions and mood are not a part of the diagnostic criteria for PTSD according to ICD-11. It was removed from the classification because they were considered to be too common of a sign of many different psychiatric conditions, and it was thought it's simply not necessary to have them in the diagnostic criteria for PTSD. So the diagnostic criteria for PTSD according to ICD-11 are still based on the stressor or the traumatic event, which is similarly defined as exposure to an extremely threatening or horrific event of series of events. And the symptom groups are re-experiencing, such as nightmares and so on, avoidance and persistent perceptions of heightened current threat, hyperarousal. A slight difference is that instead of 1 month, it must last at least several weeks, and it also leads to a significant change in functioning and so on. And now that we've reminded ourselves of PTSD, we are slowly going towards the complex part of the story. And it is really complicated, not only complex, because complex PTSD is a term we have been using for a while. We haven't always meant the same thing by using that term. So today's diagnosis of complex PTSD is not basically the same condition that was discussed, for example, 30 years ago. This current version of complex PTSD is a bit more narrow than the one, for example, described by Judith Herman, 1992. But how did this current version of complex PTSD develop? There were different conditions and syndromes proposed and described in the literature. One of these was, or now two, have also been a part of a classification. It's the middle one, and I'm going to tell you a couple of words about it. So DESNOS basically means disorders of extreme stress not otherwise specified. EC-PACE is enduring personality changes due to catastrophic events. And the final one is complex PTSD. And as I mentioned, we have a very kind of famous author in this field, Judith Herman, who published a book in 1992, Trauma and Recovery, where she basically described a condition which aims to incorporate chronic sequelae of experiencing severe traumatic events, the ones that are repeated, the ones that are prolonged in time, the ones that are like extremely difficult experiences. And she also, for example, writes in her texts that for the existence of a complex form of post-traumatic stress disorder in survivors of prolonged repeated trauma. And this paper also states that this syndrome is currently under consideration for inclusion in DSM-4 under the name of DESNOS, disorders of extreme stress not otherwise specified. So what is DESNOS? Are you acquainted with the term? Many of you have probably read it in like papers or earlier publications or stuff like that. So DESNOS was a syndrome or a diagnosis category proposed to be part of DSM-4, but it wasn't introduced in the classification itself. And the reason for that is that most of people, according to authors, does it work? Yes? Most of people who fulfill diagnostic criteria for complex PTSD also fulfill diagnostic criteria for PTSD. And because it was, I think, in the region of 90+% people, there was an attitude that there simply isn't a need to have two similar diagnoses where more than 90% of individuals will fulfill criteria for both of them. And that's why DESNOS, or this diagnostic category, wasn't introduced into DSM-4. However, it was introduced in a lot of research. So if you still try to find articles about DESNOS, a lot of research basically was done using this cluster of symptoms. And just to kind of introduce it briefly, there were 6 groups of symptoms. Alterations or changes in regulation of affect and impulses, alterations in attention or consciousness, alteration in self-perception, alterations in relations with others, somatization, which I think was quite good, basically, because it's very common. Alteration. So, what is the relationship between the complex PTSD and the other diagnosis I mentioned? And these are the enduring personality changes after catastrophic events. So basically, ICD-10 had a diagnostic category called enduring personality changes after catastrophic events, which was removed in the ICD-11 by introducing complex PTSD. And the reason for removing this diagnosis was that there was a general attitude that it wasn't well researched, that there wasn't enough evidence to support that type of a diagnosis, and that it hasn't been subjected to a lot of research. Although I must say, having worked in Croatia, which is a country which had war and there was a lot of veterans suffering PTSD, a lot of them did receive this diagnosis, enduring personality changes after catastrophic events. And the reason for that was that you had people who presented with consequences of very severe traumatic events, but they wouldn't still present with symptoms such as nightmares, flashbacks, and similar symptoms, which usually meant re-experiencing. But they would, for example, isolate themselves. They would be very kind of recluse. They would not engage with other people. They would display anger and different phenomena like that. And that there was a need kind of to put a diagnosis for different reasons, and this one was quite commonly used during personality changes. I'm going to show you what it was about. So basically, as a part of the revision of ICD-11, this diagnosis during personality changes was removed, and complex PTSD wasn't. And when we speak about complex PTSD in ICD-11, the first thing is that the traumatic event is more commonly exposure to an event or series of events of an extremely threatening or horrific nature, most commonly prolonged or repetitive events from which escape is difficult or impossible. What is also important to mention that this is not a requirement to diagnose someone with complex PTSD, and I can explain why a bit later. Such events as these ones, prolonged, extremely threatening, horrific, and so on, include torture experiences, concentration camps, slavery, genocide campaigns, and other forms of organized violence, prolonged domestic violence, and repeated childhood sexual or physical abuse. And now to the diagnostic criteria for complex PTSD. So in order to fulfill the diagnostic criteria for complex PTSD according to ICD-11, the patient needs to fulfill the criteria for PTSD, so experience of a traumatic event, and symptoms matching these three symptom groups, re-experiencing hyperarousal and avoidance. And in addition to these three symptoms, the person also has to has to present with symptoms from three symptom groups, jointly known as disorders of self-organization. It's basically this group of symptoms divided in three categories. So the joint name would be disorders of self-organization. The first one is interpersonal disturbances. The second one, as mentioned in the beginning, is negative self-concept. And the final one is affect dysregulation. And just briefly to kind of show you the relationship between these three syndromes that have been used in the past 30 years. So here is Desnos, where in addition to these similar traits like experiencing a traumatic event and so on, it was also including dissociation, somatization, changes in perceptions of the perpetrator. And then here we have enduring personality changes, which last more than 2 years. They involve hostile attitude towards the world, social withdrawal, feelings of emptiness or hopelessness. And then at the end we have complex PTSD, which basically incorporates parts of these symptoms, but they are not overlapping entirely. So in the past 30 years we had three diagnostic categories, or one of them was not included in classifications, but we still had them in use, and they are not really describing a cluster of symptoms, as you can see. And I'm only showing this because it's kind of important to understand what was the way towards today's diagnosis of complex PTSD and why it describes these symptoms as it does today. And now we are slowly moving to the actual topic of the talk, which is the treatment for PTSD and complex PTSD. So as it was mentioned yesterday, the first line treatment, or the standard treatment for PTSD would be trauma-focused psychotherapy as supported by evidence from research in treatments of these two conditions, or especially PTSD, and I'll try to explain why complex PTSD is a bit more difficult to kind of describe when it comes to evidence, knowledge about available treatment methods today. Yesterday I heard there was a lot of interesting presentations about the medication, but I just have to kind of share my own opinion. Medication is not the best treatment for PTSD. We do use it a lot, but we use it a lot because we usually don't have a choice. And I will also try to kind of come back to the point a bit later, why we don't have a choice and why we do the things we do. We do it because we want to help our patient, but it's very difficult to offer the best available treatment when you don't have a psychologist or a psychotherapist or a psychiatrist working with psychotherapy available for the coming year or 2 years. And I've seen a lot of patients who get a very good diagnosis. They're diagnosed with complex PTSD or PTSD, and then they wait for treatment for a year or two. And what do you do in that time? Well, many people usually prescribe medication because that's the only way you can help your patient, if not with alleviating some symptoms. That's also important to kind of comprehend because PTSD can be described as an illness of memories. So in order to kind of recover from PTSD, we need to do something with these traumatic memories. We need to rework them in a certain way so they don't cause symptoms anymore. And usually therapies are made to lead to that outcome. to rework through the memories, to work through the very difficult emotions connected to PTSD and complex PTSD, and to allow the patient to continue with their lives. It doesn't mean that the patient will forget what happened, but it means that the memories won't be kind of causing this type of symptoms in the same way, and they won't be influencing the function level as severely. Medication should basically be used in two groups of people. The first one would be people who don't want to go through trauma-focused psychotherapy. So if trauma-focused psychotherapy is the recommended treatment, we should always go with that first. But if a person says, no, I don't want to talk about it, I don't want to see a psychologist, I don't want to see a therapist, I don't want to talk to you about that, then we can offer the next best thing, which would be the medication. Another alternative would be if the person has PTSD and has a comorbidity, for example, with depression, with some other anxiety syndrome, for example, addiction or whatever that can be treated with medication, or even psychosis. And then we treat that condition with medication. The third option is if we want to specifically treat a certain symptom. For example, prazosin has been used for nightmares, but that's a very specific symptom we want to target. Or if the person cannot sleep, then we can prescribe some sleep medication. What is a very often occurrence, especially in specialist level services, is that we use a combination of both therapy, medication, physical activity, and so on. So these are basically the treatment options available. And now I thought we can go into a bit of detail. I'm just going to present some treatment guidelines, mostly European ones. For example, NICE guidelines in the UK are, I think, quite nicely written and quite comprehensible. So according to NICE guidelines in the UK, adults should be offered an individual trauma-focused CBT intervention to adults with a diagnosis of PTSD, or to people who have clinically important symptoms of PTSD who have presented more than 1 month after a traumatic event. And then they offer a couple of therapy methods, including narrative exposure therapy and prolonged exposure therapy. What I would like to mention is that this recommendation is very clinically relevant, because it doesn't require a formal diagnosis of PTSD to offer a patient trauma-focused psychotherapy. And I think that is a very important point in these guidelines. The reason for that is sometimes we get into a discussion, oh, is this a personality disorder? Oh, is this PTSD? Is it complex or ordinary classical PTSD, and so on? And then these endless debates basically do not lead to any functioning treatment for a patient. So what I usually say to people, ask me, oh, but how can we know if this is a comorbidity between borderline and complex PTSD? Then I tell them, well, if a person has nightmares and has flashbacks, you can still treat them with trauma-focused psychotherapy, or add it to treatment for personality disorder, for example, DBT or MBT, and see the result. If they get better, fine. If they don't, continue with treatment for personality disorder. I think it's a very simple kind of formula to use. Of course, it can be much more complicated than that, but we're going to get into that in a minute. Another part of NICE guidelines, which are also interesting, is that it describes what the trauma-focused CBT intervention should entail. So it should entail elaboration and processing of the trauma memories, processing trauma-related emotions, including shame, guilt, loss, and anger, and so on. And just these complex emotions, for example, shame, guilt, and so on, are very important to address in an effective trauma-focused psychotherapy. The patients should also be prepared for the end of the treatment, and there should be, for example, the opportunity to provide a trauma-focused therapy booster, for example, when an anniversary of the event is approaching or similar. What does the current evidence say? Which methods are the best? So I took this from the VA-DoD, the American Veterans Service. Basically, they made an overview and listed which methods have the best evidence. So as you can see, the best evidence is for prolonged exposure, cognitive processing therapy, and eye movement and reflex therapy, EMDR. Sufficient evidence exists for Ehlers and Clark cognitive therapy, written exposure therapy, which is a very kind of useful manualized treatment which can be used on a primary healthcare setting as well. And then present center therapy. Insufficient evidence, which doesn't mean that these treatments are necessarily not effective. It means that there isn't enough studies and there isn't enough evidence to support their more wider use in treating PTSD. So usually they're not a part of recommendations or guidelines, but sometimes they can be quite viable and useful. For example, ACT, acceptance and commitment therapy, brief eclectic psychotherapy, DBT, narrative exposure therapy, psychodynamic approaches, and STARE. I'm going to describe some of these in a second. When it comes to more specific guidelines for complex PTSD, as you can appreciate, complex PTSD is still quite a new diagnosis, so we don't have that many guidelines, established guidelines. There are some. For example, ISDSS has some guidance on treating complex PTSD, and in Australia they have published a part about treating complex PTSD as a part of their national guidelines. And these Australian guidelines say that on the basis of current data, specific trauma-focused psychological interventions such as CBT, exposure therapy, and EMDR appear to be effective in treatment of several of the complex PTSD symptom clusters. They also conclude that more research is needed to kind of provide more definitive recommendations for the treatment of complex PTSD. Basically, now I wanted to present a few treatment methods, starting with prolonged exposure, and based on the recommendation that we should first consider trauma-focused psychotherapy, and then probably something else if that didn't or doesn't work. So prolonged exposure is a manualized CBT-based trauma-focused psychotherapy, typically provided over a period of about 3 months with weekly individual sessions resulting in 8 to 15 sessions overall. I spoke to some prolonged exposure therapists. I myself did training in prolonged exposure, but I don't use it that often. It's a very good manualized, very pedagogical, very educative treatment. And I personally think it's very well construed and adapted to persons who had, for example, one severe trauma. And that's the requirement because the therapy builds on reworking or working through that traumatic event. Usually, trauma-focused psychotherapies start with an assessment, followed by psychoeducation, as does prolonged exposure. The therapist also explains the patient some relaxation techniques, for example, breathing exercises and so on. Therapists after the assessment and the initial session, the exposure begins. And there are two main types of exposure. The first type of exposure is imaginative exposure, which means that the person thinks or remembers what happened or writes about what happened. And the second part is in vivo exposure. For example, if the person suffered a traffic accident, in vivo exposure would be to get back to a steering wheel of a car and try to first sit in a car and then try to drive. Or if a person was, for example, robbed or raped in a certain part of the city, walking in that part of the city might be a part of in vivo exposure if it's not too dangerous for the person. Prolonged exposure is one of the most researched and well-documented trauma-focused psychotherapies, and it's also one of the most popular ones. I'm not sure if it's what the situation is in Mexico. Is prolonged exposure the more dominant method, or are you familiar with prolonged exposure? For those interested, training in prolonged exposure, if you have previous psychotherapeutic experience, is not that long, usually 4 days, and then after that there are a few cases of revision. It's a manualized treatment, so basically sticking to the solves a lot of issues. The next method I wanted to briefly present is EMDR. EMDR has becoming more and more popular, I would say, based on the questions I usually get when I talk about treatment for PTSD. This method doesn't involve working through the traumatic memory in the same way as, for example, the the prolonged exposure method was. So EMDR is based on the observation that the intensity of traumatic memories can be reduced through eye movements. The patient focuses on the traumatic memory or thought and moves their eyes following the movement of the therapist's finger. So the therapist basically instructs the patient to focus on a memory or a feeling and then moves their finger in front of the patient's eyes. The patient is following the finger for, I think, 30 to 40 seconds. And studies also conclude that EMDR may be effective in the treatment of PTSD in the short term, but the quality of studies is too low to draw definitive conclusions, according to this paper published in 2020. But recently, EMDR has been assessed as one of the methods with best evidence as well. There is also evidence that EMDR might be effective for treatment of complex PTSD. The third method I would like to mention, and this is the one I'm more familiar with, it's called narrative exposure therapy. And this method is basically adapted to persons who have had multiple traumatic events and whose, let's call it, social situation is not stable. For example, it has been widely used on refugees in refugee camps, for example. Prolonged exposure, for example, requires that the person meets in the office once a week and it has a more well-defined setting. Narrative exposure therapy is a bit more flexible in that respect, and the frequency can be adjusted as well. Basically, the narrative exposure therapy is also a standardized form of treatment, the trauma-focused psychotherapy, also manualized, and it's based on embedding trauma exposure in an autobiographical context. There's also 4 to 12 sessions of 90 minutes, and it depends on the number of traumatic events. It also focuses on imaginary trauma exposure and on reorganizing memories. I'll just give you a short vignette how a typical NET therapy begins after the assessment and the psychoeducation. One of the first sessions is the creation of a lifeline. So the therapist takes a rope or a thread and then offers the patient different symbols. Usually it's rocks or stones symbolizing traumatic events and flowers symbolizing positive events in life. So usually the patient, we put the thread on the floor and we ask the patient to mark important events in their lives with a certain symbol. It can be a stone, or it can be a flower, or it can be a stick if the person caused harm to someone else. Usually we work with stones and rocks. So every traumatic memory is marked with a rock, and every positive memory in life is marked with a flower. And I think that's quite good because it creates a sense of continuity, autobiographical chronology. It embeds the traumatic event on a lifeline, which is very important for working through it. And then sessions are built on working through the traumatic memories. One stone is addressed at one session, for example. It can be added more probably, I think, if necessary. What is also special about NET is that the patient's testimony is documented and presented to the patient at the end of the treatment, contributing to this autobiographic context or component. We also have psychodynamic approaches, and these are very popular still. However, there's not enough evidence to support a more wider use of psychodynamic therapies. However, psychodynamic approaches might be quite useful into treating trauma, especially if we tried different methods and didn't really match. I've met a lot of patients, for example, who are more complicated cases, who have comorbidities, a lot of physical ailments as well, and then they tried, for example, prolonged exposure, didn't work, or they would drop out after 2 or 3 sessions because it was just too much. Or you would have patients who simply kind of don't have difficulty of doing their homework, which influences the efficacy of what's it called, any trauma-focused psychotherapy, which involves homework and stuff that the person has to do at home. And psychodynamic approaches can be sometimes useful when it comes to kind of building the treatment alliance, establishing a good rapport with the patient, trying to build a relationship over a period of time to be able to address the traumatic memory after a while. Trauma-focused psychotherapies are just that. They're focused on the trauma. You can add things to them, but basically the point is to work through the traumatic memory so the patient would experience symptom relief. Last but not least, and this is quite kind of popular or modern, I dare to say, is the question of how do we approach treating complex PTSD as it is defined in ICD-11. And there are a lot of questions surrounding this simply because it's a relatively new diagnosis. We don't have enough research to say this is the best. We simply don't know that. But there is evidence saying that both trauma-focused psychotherapies, as I described, prolonged exposure, EMDR, probably narrative exposure therapy, and so on, are effective in treating complex PTSD. However, there is also research done on combined component approaches to treating complex PTSD, basically where the therapy is a combination of different methods aiming on different cluster of symptoms. So for examples for that in case of treating complex PTSD are SNT, which is a combination of STARE and narrative therapy, and DBT-PTSD. I think there are 2 studies confirming the efficacy of DBT-PTSD and probably 3 randomized studies confirming the efficacy of SNT. So these are promising methods, but as said, there is still not enough research to kind of establish their efficacy and recommend it as a more general treatment for complex PTSD. So what is DBT-PTSD? As you all know, DBT is basically originally developed to treat individuals with a high risk of suicide, typically used for patients with a borderline personality disorder and self-injury. And the DBT prolonged exposure protocol basically is extended DBT treatment to patients with PTSD. And in my personal opinion, it would also be good to kind of think about complex PTSD as something where, as a condition with high comorbidity. It's not uncommon for patients with complex PTSD to have comorbidity with other psychiatric diseases, including personality disorder. So I don't see it as one or the other. It can be one or the other. It can be neither, but it can be both as well. The person can both have a borderline diagnosis and have complex PTSD. And I think this method probably would be quite a good idea for that type of a patient. But also for patients who probably have an established borderline diagnosis and have some symptoms of PTSD as well. So besides basic DBT treatment elements, DBT-PTSD also includes frontline evidence-based treatment components for PTSD, such as prolonged exposure, treatment of behavioral dyscontrol, and fostering coping skills. Finally, I would like to mention SNT, which is also one of the multi-component treatments proposed for treatment of complex PTSD. Basically, SNT stands for STARE plus narrative therapy. STARE is skills training in effective and interpersonal regulation plus narrative therapy, which was initially developed as a face-based intervention for childhood abuse survivors. And as it says here, the first module, or STARE, includes skill training to develop emotional and interpersonal resources that have been compromised by long-term trauma. And the second module, narrative therapy, employs exposure and cognitive restructuring techniques to alleviate PTSD symptoms. As you can see, the idea behind these is to address both the core PTSD symptoms, such as re-experiencing, avoidance, hyperarousal, and so on, but also to address the symptoms that now are part of this symptom cluster called disorder of self-organization, which is a requirement for complex PTSD diagnosis. As said, some studies confirm that these are promising methods, but further research is needed to confirm their efficacy in a broader context. So probably we'll know more in the upcoming 5 or 10 years. And then we'll probably change the diagnosis, so we'll have to start over. But that's the fun part of psychiatry, I think. And in addition to that, and I usually focus on psychotherapy and medication, I don't really widen it to other fields, but sometimes it's quite good to mention that there are some other potential treatments which can be recommended well to our patients, especially if they've tried a lot. For example, horticultural therapy may lead to decreased cortisol levels and improve depressive symptoms in veterans, according to one randomized controlled study. Sports-oriented occupational therapy, yoga, mindfulness-based interventions, community-based interventions. All of these can be a complement to trauma therapies. Either they are classical trauma-focused psychotherapy or multi-phased psychotherapies. When talking to severely traumatized people, you usually hear that they like spending time in nature. A lot of them like to fish. Some of them like to work in the garden. So gardening, fishing are also some activities which I would typically recommend if it's appropriate to a certain person who experiences these more chronified PTSD symptoms, especially hyperarousal. Being in nature calms us down. A person who has an elevated arousal, heightened alert, needs a very calming environment. Usually being in nature, in a forest, experiencing the calm and relaxation is very beneficial for our patients with chronic PTSD. And just finally, when it comes to transcultural aspects, there are evidence supporting the cross-cultural validity of PTSD. There is, for example, certain areas where we need further research when it comes to this cultural validity. For example, groups of symptoms related to avoidance or numbing and so on. When it comes to complex PTSD, we have a similar conclusion that there is evidence for cross-cultural validity of the diagnosis, but there are areas where we need to be a bit more careful. For example, in East Africa, it is possible that the symptoms attributed to disorders of self-organization may lead to a higher potential for meeting CPTSD diagnosis because East Asian cultural norms of modesty, humility, and emotional restraint may influence responses to questions related to disorders of self-organization, which are connected to negative self-concept. For example, I feel worthless, or disturbances in relationships. I feel distant or cut off from people. So sometimes cultural norms can influence how people answer these standardized questionnaires, which serve us as diagnostic tools. So I think since this is still a new diagnosis, there is a need for cross-cultural studies on the validity of complex PTSD in different cultures. And finally, disparities. As I said, like all of these nice therapeutic methods, prolonged exposure, therapy, suggestions of combined methods, and so on. But then the sad reality is that it's not really widely available in many parts of the world. Even in the most developed countries, there are long waiting lists for trauma treatment. So this WHO World Mental Health Survey did show us some numbers when it comes to the quantity or number of people receiving PTSD treatment. It said that less than half of respondents with 12-month PTSD reported seeking any type of treatment. Individuals in high-income countries twice as likely to seek treatment and as those in lower middle income or upper middle income. A quarter of respondents with PTSD reported seeking specialized treatment 12 months before interview. Only 3.2% of respondents in lower income countries receiving treatment compared to 28.7% in high. And if you think about all the wars that we've been talking about, all the conflicts and so on, well, I would say that most of them are not in high-income countries. So you already have a situation where the reasons or groups which have a higher incidence or prevalence or vulnerability to PTSD live in environments or countries where access to help is not, or where help is not widely available. So I think that's also something which is good to know. And to conclude, and I think I'm on time, yeah? There is evidence about the efficacy of trauma-focused psychotherapy in treating PTSD. Trauma-focused psychotherapy is the recommended treatment for both PTSD and complex PTSD, and screening, assessment, and interventions for PTSD and complex PTSD need to be culturally and linguistically appropriate. Thank you so much.